speaker is Dr. Tutul Chakravarti. She will be talking about an important treatment modality for angle closure, laser peripheral iridectomy or iridotomy, and argon laser peripheral iridoplasty.
While Tutul comes up, are there any questions that anybody would like to ask about imaging? As Dr. Shanta pointed out, most of the information we want to get for clinical management, we're able to get on a good gonioscopy. So the question is, how does one get as much as we can? So we'll come back to that with Dr. Sirisha, but Dr. Tutul is ready.
Good morning. When and how to do a laser PI and LPI. Now first we would like to discuss about the classification of primary angle closure, types of PAC, PACS, PAC, PACG and APAC. Now LPI is the cornerstone of angle closure management in primary, acute, subacute or chronic angle closure. LPI increases angle width in all stages of PAC. LPI breaks relative pupil block. Next question is indications of LPI. Now the efficacy of LPI is dependent both on the underlying mechanism causing angle closure and the stage of the disease. Like in PACS, only 0 to 8% need further treatment, while many PAC and ACC, they need further treatment like 42 to 67% in PAC and ACC 21 to 47%. However, most of the PACG, like 83 to 100%, they need further treatment. Now other indications of LPI, play to iris configuration, combined mechanism glaucoma, contralateral eye in APAC, secondary angle closure with pupillary block, aqueous misdirection. LPI eliminates a reverse pupillary block in pigment dispersion syndrome. It does a prophylactic LPI where iridocorneal angle change due to some systemic drugs like topiramate. Now in the an informed consent is needed. You should inform the benefits of LPI. For PACS, it prevents PAC or PACG. Now you also inform the risk of LPI, like IOP spike, dysphotopsia, AC bleeding, cataract progression, risk of closure, corneal damage, and the chances of repeat procedure. Now pilocarpine 2% is needed to make the iris stretch, reduce the iris thickness. Now please be careful when you are using this for high myopic. Now brimodidine or apraclonidine minimize post-LPI IOP spike and bleeding. You can use acetazolamide 250 mg or 500 mg topical proparacaine. What are the lenses for LPI? You can use either Abraham lens or Weiss lens. Now which laser to use? That is Argon or YAG. Please remember Argon laser LPI is associated with high rate of failure, that is 20% and closure 30% in brown eyes. Less total energy is required in the ND-YAG than with the Argon laser. These are the laser parameters. Please remember, use the minimum amount of energy to create the iridotomy. Lens capsule damage is possible more than 2 millijoule energy. Now what are the sites of LPI? Some recommend superior quadrant between 11 to 1 o'clock. Please remember, this is 10 to 7% superior dysphotopsia in superior LPI than 2.4% in temporal. In the presence of silicon oil or gases, perform inferior LPI. In AC bleeding, superior is more than inferior, no difference between superior versus temporal location. If the first few laser pulses are ineffective in the area selected, consider moving to a new site. In temporal 1, peripheral 1/3 of the iris, just anterior to arcus and within the iris crypt. PI is easier at thin areas at the base of the iris crypts, slightly superiotemporal to avoid long posterior ciliary nerve and avoid prominent iris vessel. What is the end point of the treatment? Iris is treated until gush of fluid seen flows from the posterior into the anterior chamber. Size, ideal iridotomy size at least 150 to 200 μ. Transillumination through the iridotomy is not a reliable indicator of patency. Manage bleeding. Now apply pressure to globe using laser lens. You can use Argon or diode laser to coagulate area of bleeding. Now here we can find is a small LPI opening with the white collagen strands at the stroma, and you can see a thin membrane at the base of the PI. Now repeat LPI is needed, and here we find the PI is completely penetrated and this is a widening of the anterior chamber angle. IOP increases more than 10 millimeter of mercury in 30 to 35% of the eyes. So check IOP 30 to 60 minutes after LPI. Prednisolone acetate 1% 1 drop 4 times daily for 1 week. Follow up in the 1 to 2 weeks to check for AC reaction, PI patency and gonioscopy to assess improved angle configuration. Regarding bilateral same-day LPI, when the patient access to eye care is limited, you can do it. Smaller iridotomies are known to be at increased risk for closure, that is 60%. Closure may occur within the first 24 hours. Most closure occurs within the first month. Any doubt about the patency of PI, the opening should be enlarged or a second PI should be created. Now, ZAP trial found a 2/3 decrease in PAC occurrence after LPI. The question is, in that case, should we do or treat all occludable angles with LPI? Now, in that case, we have to follow the natural history of PACS. How much PACS is converted to PAC? Now, again, ZAP trial found conversion from PACS to PAC is relatively low, and most PAC cases were asymptomatic. Again, the cataract progression rate was significantly greater in 6 years following LPI for PACS. Considering all these, widespread prophylactic LPI for PACS is not recommended. Now, prophylactic LPI prescribed primarily for the high-risk population, like those who are having baseline higher IOP, fellow eye in APAC, and also shallower limb and anterior chamber death. Next, come to ALPI. ALPI can be used in treating chronic angle closure when angle closure persists after LPI. In 20 to 30% of eyes, a patent PI may fail to relieve angle closure and treat the underlying disease mechanisms such as plateau iris configuration. ALPI eliminates appositional angle closure resulting from mechanism other than pupillary block and angle closure originating at an anatomical level posterior to the iris. What are the indications of LPI? LPI can mechanically open up the angle in APAC in the early stage of non-pupillary block, AAC, plateau iris syndrome, nanophthalmic eye, iris and ciliary body cyst, safe and effective as a first-line treatment of acute phacomorphic glaucoma. These are the ALPI procedures. In ALPI procedure, aim at producing a contraction and burn at the post-peripheral portion of the iris. These are the scars from LPI in eyes with plateau iris syndrome. Now, a recent study, they investigated the efficacy of ALPI versus PGA in PAC. 80 PAC or PACG subjects were enrolled who underwent LPI and had at least 180-degree persistent appositional angle closure and IOP more than 20 millimeter of mercury after LPI. Now, after 1 year, ALPI was associated with a huge failure rate, that is 30% and lower IOP reduction compared to PGA therapy. Conflicting results regarding efficacy of LPI, that is regarding change in extent of peripheral anteseneca, reduction of IOP, and anterior chamber morphology between ALPI and LPI alone. So we could conclude that in LPI
Dr.
increases
Tutul, can you
angle
summarize,
width.
please?
Yeah, just the last slide. LPI increases angle width in all stages of PAC and reduces IOP in eyes without extensive angle or disc damage. Additional treatment is needed after LPI in PAC, APAC, and PACG eyes. Angle closure persists after LPI in non-pupillary block of angle closure. Treating all PACS with LPI with hope of preventing progression to PACT is not recommended. Regarding LPI, all these studies prove that the evidence is very uncertain about the effect of LPI. But please remember that ALPI is an opinion to consider in the acute stage of the disease. Thank you.
Yeah, very nicely covered, Dr. Tutul. Like you very rightly pointed out that only 22% of PACS progress to PAC. So prophylactic PI in all cases of PACS is not needed. What are the cases of PAC in which you would recommend doing PI?
Those who are having higher baseline higher IOP, and also those who are, I mean, for PAC, if the baseline IOP is higher, I can do the AIOC-PI. In that case, I do not discriminate. But for PAC-CS, I can discriminate.
Yeah.
I mean, when to do the AIOC-PI. Madam is not happy.
I think Tutul mentioned something about cataracts increasing 6 years after a surgery at Chennai.
This is
laser iridotomies. But I think both the Singapore study and the 14-year ZAP study showed that there was no increase in cataracts.
Yeah,
so I think it depends on what you
the
use.
ethnicity of the population.
Possible, and also what
they
was
were not
used.
visually threatening. There were a lot of them were cortical cataracts.
So Thank you, ma'am.